help you? Oh no. Let me bang it really hard.
Like all the other.
Shut in.
That's so stupid.
It's gonna suck for the rest of your life. Delete scene bad. Google how to change the delete key.
Maybe I pressed something on accident. Oh, it works up here.
Go back down there.
Ah, okay, that was weird. I was freaking out because like, oh, my life's over.
I'm gonna need a printing version. Or is that all printed today for the quiz? Oh, okay. My laptop broke. I don't know. So it internally broke and it's not working. The screen is just completely dead. So I have to. No. So Apple told me they'll fix it, but it's gonna take 7 to 10 days.
Okay.
Yeah.
I posted an announcement last Friday.
Oh, okay.
It's all on paper.
Okay. Thank you.
How cute.
The butterfly one's pretty cool.
I want to make a quick announcement. Guys, the bake sale went well. Thank you guys for giving all your insight. It went really well. Thank you.
Yeah, I
The
even bought
pretzels
something.
were like so good. They went so fast. And I just want to we're not fundraising now for the banquet as much, correct? That's already done for. So just let you guys know, no stress about that, okay? But whatever, I just really appreciate that you guys came in last minute and came through. So thank you.
Thank you, Lucille.
Also, there'll be Vespers April, not this weekend, typically it's the third weekend, you know, of the month. It'll be next weekend because Travis, he can't make it this weekend. So
Is that Trammell?
Trammell, yeah. Yeah.
Awesome.
Yeah.
Where are your favorite students?
At Dr. Moretta's house. Not this weekend, guys, the next weekend. Okay? He's our featured speaker, so please come. Please come and support.
I wish I could come.
He told me to say hi to you. But come Shirley.
I wish I could come.
Come, you can come.
Oh, Mexico, I think, isn't it? Yeah, the last weekend of April.
Okay, I think so.
I'm on the mission trip.
Oh, okay.
I wanted to go. So if you would take your seats and shut your laptops. In fact, you can actually put them away because we're not going to use them for a quiz. Oh, thank you. Would have missed half my story. So I'd like you to humor me for just a moment.
I'm going to share with you a story. It's an old story, and some of you may have already heard it. But every time I hear this story, or I tell it to my class, it chokes me up. So I'm going to share it with some visuals this time. Jeremy was born with a twisted body and a slow mind, and a chronic terminal illness that had been slowly killing him his young life. And still his parents had tried to give him a normal life as possible, and they sent him to St. Teresa's elementary school. At the age of 12, Jeremy was only in second grade, seemingly unable to learn. His teacher, Doris Miller, often became exasperated with him because he would squirm in his seat and drool and make some grunting noises. But at other times, he spoke clearly and distinctly as if a spot of light had penetrated the darkness in his brain. Most of the time, however, Jeremy irritated his teacher. One day, she called his parents and asked them to come to St. Teresa's for a conference. As the Foresters sat quietly in the empty classroom, Doris said to them, "Jeremy really belongs in a special school. It isn't fair to him or the other students. Why, there's a 5-year gap between him and the other students." Mrs. Forrester cried softly in her tissue while her husband spoke. He said, "Miss Miller, there is no other school like this nearby. It would be terrible shock for Jeremy if we had to take him out of school. He really likes it here." And Doris sat for a long time after they left, staring at the snow outside the window. Its coldness seemed to seep in her soul. She wanted to sympathize with the Foresters. After all, their only child had a terminal illness. But it wasn't fair to keep him in her class. She had 18 other youngsters to teach, and Jeremy was a distraction. Furthermore, he would never learn to read or write. Why waste time trying? As she pondered the situation, guilt washed over her. "Oh God," she said, "here I am complaining about my problems are nothing compared to this family. Please help me be more patient with Jeremy." From that day on, she tried hard to ignore Jeremy's noises and his blank stares. And then one day, he limped over to her desk, dragging his bad leg behind him. "I love you, Miss Miller," he exclaimed, loud enough for the whole class to hear. The other students snickered, and Doris's face turned red. And she stammered, "Why, that's very nice, Jeremy. Now please take your seat." Spring came, and the children talked excitedly about the coming Easter. Doris told them the story of Jesus, and then emphasized the idea of new life springing forth. She gave each of the children a large plastic egg. A large plastic egg. And she said, "Now, I want you to take this home and bring it back tomorrow with something inside that shows new life. Do you understand?" "Yes, Miss Miller," the children responded enthusiastically, all except Jeremy. He just listened intently. His eyes never left her face. He did not even make his usual noises. Had he understood what she had said about Jesus' death and resurrection? Did he understand the assignment? Perhaps she should call his parents and explain the project to them. That evening, Doris's kitchen sink stopped up. She called the landlord and waited an hour for him to come by and unclog it. And after that, she still had to go grocery shopping. She completely forgot about phoning Jeremy's parents. The next morning, 19 children came to school laughing and talking about their plastic eggs in a large wicker basket on Miss Miller's desk. Now it was time to open the eggs. The first egg Doris found, she found a flower in it. And she said, "Oh yes, a flower is certainly a sign of new life. When the plants start peeking through the ground, we know that spring is here. A small girl in the front row waved her hands, and she said, "That's my egg, Miss Miller." And the next egg contained a plastic butterfly. We all know that a caterpillar changes and grows into a beautiful butterfly. Yes, that's like new life. Little Julie smiled proudly and said, "Miss Miller, that one's mine." And next, Doris found a rock inside, and it had moss on it. And Miss Miller said, "Yes, that's like new life too." And the little boy from the back, Billy, said, "My daddy helped me pick that one." And then Doris opened the fourth egg. And then she gasped. The egg was empty. Surely it must be Jeremy's, she thought. And of course, he did not understand her instructions. If only she had not forgotten to call his parents. Because she did not want to embarrass him, she quietly set the egg aside and reached for another egg. And suddenly Jeremy spoke up, "Miss Miller, aren't you going to talk about my egg?" And flustered, Doris replied, "But Jeremy, your egg is empty." And he looked into her eyes and softly said, "Yes, but Jesus' tomb was empty too." And time stopped. When she could speak again, Doris said, "Do you know why the tomb was empty?" And Jeremy said, "Oh yes, Jesus was killed and put there, and then his father raised him up." The recess bell rang, and while the children excitedly went outside in the schoolyard, Doris cried. She was cold inside that was melted completely away. He got it. 3 months later, Jeremy died, and those who paid their respects at the mortuary were surprised to see 19 eggs on top of his casket. All of them were empty. He got it. He understood. Sometimes we don't take the time to remember the things that are really important in our life, and we get all caught up. And I have had a number of emails and people come and stop by in my office saying, "Oh, I didn't do well on this quiz, I didn't do well on this, I don't understand this, I did a mistake on my homework, blah, 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 blah." That's all pales. We're going to get it, and we're going to make sure you understand it. But the most important thing, if you learn nothing more from me about anything in dental hygiene, that you remember this story, that the egg is empty and the tomb was empty because Jesus died for each one of you guys. And don't forget that. We're going to get dental hygiene. That's okay. You're going to get this. If you get this, everything else is going to be just fine. Any prayer requests? Okay, let's bow our heads. Father in heaven, thank you so much for this Easter season that's coming up that helps us to remember all the gifts that you give us each and every day. But the most important gift that you gave us is Jesus. I pray that you'll help us to remember that this week in the things that we do, in the things that we study, the people we come in contact. I pray that you will bless us, bless our class time together, and help us to not forget your gift. We pray in your name. I didn't mean to make all of you cry. But I love this story. So let me do this. You can set up stuff. Are there any questions before I put out the quiz? Or would you like to have her lecture first and then do the quiz after? I'm open. Quiz first? Okay. Okay, everything else you get? Just a writing utensil. I brought mine.
Pretty light.
finished, if you would turn your paper over and put your pencil on it or pen on it so I know who's finished. Start wrapping it up. Take your papers and pass them down this way.
That's 3.
Okay, soap. What does SOAP stand for? Subjective, objective, assessment, and plan. So where does the subjective get found? Lexicon, okay? Objective, okay, what you see. Assessment,
Talking with the patient and assessing
At
how
risk.
they sound.
okay, what effect is happening to the patient, and your plan. Okay, what modifications, what are we going to change, what are we going to watch for? Okay, 3 important dental reasons we should find out about drugs our patients take. Effects on bleeding. What else? Interaction between other drugs that might get prescribed. Side effects of other drugs that they're taking, such as something that might cause xerostomia. Good. And there may be other answers too. That's why I put it in a written test rather than on example 5, so that I can actually read through and see what it is. Under what tab do you find lexicomp in Axiom? Links. Links. And then from links to patient assessment. Good. Okay. If you're not on campus, where do you find lexicomp? Lexi.com. Okay. And yes.
What if we just put the website and then we have to add the password and username?
Yeah, I explained like how you do it.
Yeah.
I thought you meant like you don't have access, so you have to use like the dental login and the password outside of it.
I think it's good.
Okay.
What else?
Okay, so to add a treatment note, you must highlight the treatment and press Control R. False. What do you do? Right click. Add a treatment note. General note. Okay, good. All right, I know a lot of you have some concerns. I'm going to address those after we finish Dr. Kim's lecture. Now we're going to switch gears from medications to pathology. If you find a lesion in your patient's mouth, what do you do? What's the process? How do you find someone to come look at? Who looks at it? And how to go from there. So if you give her your attention, and we'll get through this probably about 20 to 30 minutes. Then we'll take a break, and then we'll come back and discuss some clinical stuff. Yes, Sarah.
Question things like the slides. So after when we mentioned 2 or 3 medication, so on a lexicon, so I didn't understand what or how can we do it. So after the slides.
So go backwards on your slide.
Where? Can you specify?
Yes, that one that issued 2 or 3 medication on it. Yes.
On this
No,
one?
not that one. It's not just one medication. It's 2 or 3.
This one?
Yes, I think so. Yes.
So, or were you wondering what that is?
When the patient takes 2 medications, so 3 medications, we stare and then we don't see the interaction between them.
Yeah.
How should we do that?
You guys listen up, please.
So these three medication, that's what patient's taking.
Yes.
So it doesn't matter. It can be 2, it can be 3, it can be more. You just put it in right here, search drugs, okay? And just put the name on it. And then the next one, that's allergy the patient has. So allergy, it can be ampicillin, it can be penicillin. Yeah, just add and search. So you're basically adding the list. And then the next is you go to medication categories. So that's where you put the medication that you want to prescribe. Okay? So in this case, I assume that this patient needs antibiotics. Okay? So I clicked medication categories and then I searched the medication for odontogenic infection. Okay? And then it will give you, so I just click that one. And then below you click analyze. Okay? And then it will give you the result. Yeah, it will give you the result, but X should be, you need to avoid combination because there will be interaction. Okay? So ideally, if you have green, then choose that drug. But this yellow, monitor therapy. So still okay, but just you monitor. Okay? Okay. Okay, so I'm glad to see you again this week. I hope you all had a good weekend. Okay, so I'm going to talk about oral path consultation. So yeah, you will see some oral path lesion clinically or radiographically too. Okay? So you are wondering, oh, what should I do? Okay?
We have wonderful oral pathologists here. You're all familiar with these cases? Yeah? Yeah. So they are willing to help you, to make diagnose and how to treat patients, but you need to do your own work, okay, before they come to your chair. So I'm going to go over what that is. Okay. So oral path consult. So if you see something unusual, you can call oral path consultation. Okay. So it's usually first come and first served basis. So no charge. That's really good. No separate charge. So it's like an on-call base. So you just call and then ask, if they can come. Okay. The on-call consultation means that's when you saw the lesion for the first time. Okay. And sometimes you need to request follow-up appointment. It's literally for follow-up. So you saw some lesion, so you had initial consultation, but let's say Dr. Richard said, okay, let's have patient come back in a couple weeks so that I can just re-examine the lesion. Then you need to do follow-up appointment. Okay? So follow-up appointment, usually you need to see the doctor who originally saw the lesion. Okay? You need to stick to that person because that doctor gave you some recommendation how you deal with the lesion. Okay? Your PowerPoint might say this one as PM, but I didn't notice the error, but you need to change this to AM. Okay? So Monday to Friday, every day, okay, but it's usually 9 a.m. to 11 a.m. Okay, morning, and PM, it's usually 2 to 4 p.m. So you can call before 9 a.m., but they might not come before 9. Okay, so this number 83664. Okay, you can ask your coordinator, but if you memorize it, it's much easier, right?
We have it posted in our clinic there, right by
Okay,
Jan's desk.
good. Initial oral path consult anytime you can just call. But follow appointments, you can just call this time or you can make an appointment. Okay? So you can contact the doctor ahead of time. Then they might say, okay, let's do follow appointment at 8 a.m. or 4 p.m. Okay? It's up to their schedule. But that's for follow appointment. So I confirmed this schedule with Dr. Richard's last week, so it's updated schedule. Okay. So you call this number, and then one of the OMFS department staff will be answering the call. You need to let them know where you are. Hygiene clinic. You will say hygiene clinic. My chair number is this. Okay. So those two they need to know. Okay. So the faculty will be contacted by OMFS staff, and then they will come as they are available. Okay, you may wait, I don't know, maybe 10 to 20 minutes or more than that. It depends, the waiting list. Okay, if they don't have any consultation going on, they can come right away. Okay, but the important thing is, if you see this kind of things, and then if you need consultation, you are responsible for working up the condition, okay? Prior to calling for consultation, okay? That's ideal because they might come right away, right? But if you didn't prepare, okay, and that's not good. So it's ideal to do your work before you call the consultation, okay? So you need to document your lesion. That's also SOAP format. So we are going to go over how to SOAP it up. Okay. Before the consultation, another thing you need to do, you need to enter the code as well. Okay. So initial consultation, you are going to put this one in treatment history. Okay. Oral path consultation. If it was a follow-up care, then you need to put the second one. Okay. And then they will help you how to organize the soap. I'm going to show you soon, but we are going to make a soap under page 3 of axium format, and then we usually copy and paste to the general notes. Okay? But that part, I see Dr. Richards is usually helping students. So once you make a good soap under page 3, the general note, you can just copy and paste. Okay? So what does workup mean? Okay? So you need to document the condition. So you need to thoroughly examine the lesion by yourself. Okay? And you also need to ask patients some questions because you want to know about the history of the lesion, right? So you are going to ask some questions for patient, and then you are going to document under page 3. So how do we make a document? It's SOAP format again, okay? SOAP. So S, as you all know, that's subjective, okay? Subjective finding is from who? This case. Patient, yeah. Okay? So you are not using lexicon for this, but subjective part is from your patient. Okay? And objective, again, that's your observation. Okay? Your clinical finding or radiographical finding. So you need to describe the lesion as you see. Okay? Assessment. Assessment is diagnosis. Okay? So you're going to make a diagnosis. Sometimes you don't know what that is, right? But you have some idea, okay, it looks like this, but I'm not sure, okay? Then you can make differential diagnosis, okay? So you can put the diagnosis that you think, oh, this might be the closest one, you can put it as number 1, but second one, third one, any possible diagnosis. I will show you the example soon. And then plan. We're going to make a plan for that lesion. Okay? Bless you. So let's go over some cases. Okay, you saw this lesion on your patient's mouth. Okay? So what do you want to ask your patient? Yeah, how long has it been there? Is it painful? Good question. Any other question? Yes.
Have you had this before?
Have you had this before? Or you can ask, do you have this kind of lesion anywhere else? Okay. What else? Have you noticed it? Yeah. You need to ask, were you aware of it, or did you know about this lesion? No. Anything else?
You'd be surprised, the majority of the patients don't know what's in their mouth. They don't even know they have something.
Yeah. Any other question? How about the size? You wanna, yeah, do you think is it getting bigger? If patient was aware of this lesion, you wanna ask the size has been changing, or has it been the same way? You wanna ask. Okay? And then oral path lesion is closely related to patients' smoking history. Yeah, that's one of the big reasons that they have oral path lesion. So you want to ask about some smoking history too. Okay? So for example, are you aware of this lesion? My patient said, yes, I knew about it. Okay? Is it painful? No, not at all, but I bite it regularly. Okay? Do you see these 2 dots? What is that? That's maybe from biting. That's petechiae, like blood spot. Okay? How long has it been there? Patient said for several months. Okay? Do you smoke or drink? Patient said, no, I don't smoke. Okay? So it can be an example of questions that you want to ask. Okay? So subjective findings, this is pretty good. So we talk about, were you aware of this? Is this your first time you have had something like this? And clinical course. Okay? Do you think this lesion is healing or getting worse? Okay? The size changing? Okay? So these are a good subjective questions. Okay? Objective. So objective is your observation, your examination. Okay? So Dr. Richards wants students to describe these in the SOAP. Okay? So location. Location is very important, right? Where the lesion is. And lesion type. Okay, I'm not going to go to too details because you're learning it from Dr. Richards, but lesion type is a nodule or papule, like flat lesion, or vesicle, like
Have you guys gotten to that part yet?
blister. Okay,
Yes.
good.
Okay.
Okay. And size, clinic supply has ruler, so you can borrow it. Or if it's small, I usually use perio probe. Okay, perio probe just measure the size. Okay, so either centimeter or millimeter is okay. Shape is it irregular, regular, round. Okay. Color, you always need to write down color. And texture, is it smooth, rough, papillary? Consistency too, like firm, fluctuant, smooth. Number, is it single lesion or multiple lesion? Demarcation, that's the border. Okay, is it well defined or diffuse margin? So these are what oral pathology is looking for. Okay, so you need to examine the lesion by yourself and describe it. Okay? Just do your best. They will help you. They will modify, some of things, but just do your best. Okay. So this case, location where it is. Yeah, right buccal mucosa on the occlusal plane. Lesion type. Nodule. Good. So, okay. Size. Okay. I measure with a perio probe. It's about 1 centimeter by 1 centimeter. Shape, round. Okay. Color, yeah, normal mucosa color. Texture. Oh, why this one is coming up? Consistency, soft and somewhat depressible. Number, single. But texture, you can say smooth, but maybe round. Demarcation, well-defined margin, pain, no pain. Okay, you want to know if it has pain. Okay, patient has pain. And lymph nodes, normal. Sometimes some lesions can be associated with other disease like cancer. So, when you do extra or intra exam, you examine the lymph nodes too, right? So I checked it and everything was normal. So that's your objective finding. Okay. So what's your assessment?
Where do we put petechia?
Oh, it's under objective. I think I included in the SOAP. You can just make a note. Yeah. Okay. You can say, yeah, I noticed 2 petechiae on the lesion. Okay. Assessment. What's your assessment? It's pretty common lesion. So it's fibroma, okay? But if you are not sure, fibroma, you can say another differential diagnosis. What is that? Possibly it can be lipoma, it can be pyogenic granuloma, okay? Sometimes it can be papilloma. So if you are not sure, you can just, usually 3 differential diagnoses is good, okay? But this case, it's pretty much sure fibroma. So I just put 1, but oral pathologists usually want you to write down like 3 differential diagnoses, okay? And plan, what are you going to do? So oral pathologists, they don't really like you put oral path consultation because it's happening, So plan should be something that you want to do to treat this lesion, okay? So this kind of lesion, for treatment, you can do biopsy, right? Or if it's not harmful, you can just monitor, right? So excisional biopsy or monitor. So this is the summary of assessment and plan, okay? Assessment, a list of the most likely diagnosis, which is differential diagnosis, and determine your plan, okay? Biopsy. Sometimes if you see herpes or aphthous ulcers, candidiasis, attending will know what you need to do. Like candida infection, you can prescribe some nystatin, antifungal ointment or cream, okay? So you can put those treatment in the plan, okay? And then you can say monitor for 2 weeks and then re-eval, okay? Referral. But oral path consult is not an appropriate plan, okay? So develop your plan based on your differential diagnosis, okay? So this is the SOAP. So I think, yeah, I added 2 petechia present on the surveys, okay? So subjective, what you hear from patients, objective, the description of the lesion, assessment, and plan. Yes? Question?
Who's to say if you can't do the oral path consult that day, you have to schedule an appointment? You still not wise to book oral
Then put it in, but I want to see other plans too.
Okay.
Okay? So good point. If you cannot get oral path consult, then you can put, oral path consult plan, but just put other plans too. Say monitor or biopsy, excisional biopsy, or prescribe some medication if it's like a viral or antifungal. Okay. Okay. So example of differential diagnosis. Okay. The skin lesion. It's pretty common too. Okay. So it can be just actinic keratosis, sometimes melanoma, and I hope this is not, the real case, but that's the possible diagnosis too. So this is the example of diagnosis for this lesion. Okay. So we talk about fibroma. This can be your differential diagnosis.
For stuff like right there on the skin or even like around the lips or the nose, are we responsible for that and soaping that up, even though it's not in the
Skin
mouth?
too. Yeah. Yes. If you see, because I think you learned this kind of lesion in oral path class too. Yeah, you will learn. If you haven't learned, but yes, responsible for skin. So what if? Oh, I have no idea. What I put in assessment. Okay, my mind is blank. I don't have anything in mind for differential diagnosis. Then what can you do? The good thing is, the clinic supply has oral path book. Okay, so you can actually, at the end of the book, there's an appendix, and then it has really good section that shows differential diagnosis. So for example, yeah, I usually just check out the book so that I can just look up the differential diagnosis too. So for example, okay, appendix, it's toward the back of the book. Okay, so differential diagnosis. Let's say if you saw some white and red lesion, okay. So it has many sections, like radiographically radiopaque lesion or radiolucent lesion, so many sections. But let's say if you saw some white and red lesion in mouth and then you are not sure about differential diagnosis, then it has a bunch of lists, but you can just see which one is more close to your lesion. Okay? So this book, don't forget that we have a book upstairs so that you can refer. Okay? Okay, so where do you document the lesion? Are you familiar with this page 3? Yeah? Okay. So page 1, health history, 2, dental history, but page 3, that's from your extra oral and intraoral exam. So if you see something unusual, you need to click yes. Okay, are there any abnormality present? Yes. And then the bottom of this page 3, you will have this narrative area. You can just double click, okay? Then the blank box will pop up, okay? And then you're gonna write the soap here, okay? Dr. Richards will check if you make this soap during the oral path consultation, okay? So remember page 3, soap, and then actually you need to draw the lesion, okay? So these are 4 areas, then you can double click, okay? So for example, let's say if you click this soft tissue tongue, gingiva, palate, void teeth, okay, you double click that one, and then you will see this diagram, okay? Then you just pick, red color is more popular, okay, because it stands out, okay? So red color, you just draw that fibroma that we saw, right? The fibroma, it was right side buccal mucosa on the occlusal plane. So you just draw that lesion. Okay? So that's what you need to do. Okay? Page 3, sew and then draw the lesion. Okay? If patient is edentulous, then we have some without teeth option, and we also have panoramic view. Let's say if you saw bony lesion, okay, bony lesion on panoramic radiograph, then if you click the first one, you will see the panoramic view. You can just draw the lesion over there. Okay? Case presentation. So when your oral pathologist comes to your chair, if you made a good soap, it's really easy to present. Okay? Because you can just refer your soap. Okay? My patient said she was aware of this lesion and it has been there for several months. The patient denied the size is changing, no pain. Okay? And then observation, you already described, right? So you just present the case to your oral pathologist and assessment. I think this is fibroma, irritational fibroma, but it can be maybe lipoma or it can be pyogenic granuloma, but I'm pretty much sure this is fibroma. And my plan is the biopsy will be ideal. However, patient doesn't mind monitoring it, so we are going to monitor for how long. Okay? So if you present the case like this, Dr. Richards will be really, really impressed. Okay? So make a good soap, then your presentation will be really easier. Okay? So on-call faculty, they will review your document and they will look at what patient has, and then they will just modify your documentation. Okay? If they need to change your differential diagnosis, they will change it, and then they will determine, the best management for this patient. Okay? And then they will help you copy and paste the good soap that they modified, and then they will attach to oral path consultation code. Okay? What if it's normal variation? Okay? This is not pathology, right? What is this? Yeah, just tori. It's just normal variation of some anatomy, right? But still, we want students to just draw and then just mention it. Okay? If it's totally normal, like bilateral tori, I teach dental students, you just write it. You don't have to soap it up. Tori, it's pretty much sure tori. Okay? But they still need to draw it. Okay? Where it is, and then just mention it. Okay? Linea alba, mention it. Okay? I have another example. Okay? So you see this lesion. Okay? What do you want to ask patient? Yeah, are you aware? How long? Any pain? Any pain? Yeah. Yeah, size changing.
Is it anywhere else?
Yeah. Anywhere else? Do you have this kind of lesion? Other area? So these are pretty good questions. Okay. So yeah, patient was aware. No pain. How long? Many years. Is this healing? Getting worse? Staying the same? It seems like it stays the same. Okay. So tobacco, patient denied tobacco.
So, do you describe the lesion to them, or do you use it
To them?
to the patient? Sorry.
Patient?
Yeah. So, if you notice that and say it's the first time,
Oh,
do you
okay.
just
They
describe?
don't know?
Yeah.
Describe, or you can use your hand mirror. You can show it to them.
Okay.
If it's a visible area. If it's down
And if
the
it's
throat.
not, like,
If it's
what-
not, yeah, you describe it. I see some purplish color lesion back here above the second molar. Okay, did you notice it? Probably not. Okay. Yeah, you just describe it. Let them know there is some lesion. Okay. Some spot.
And then after we let them know about the lesion, just let them know we're going to go ahead and get a path consult?
Yes. Yeah. So we just want to make sure this lesion is okay. Sometimes it's just normal variation, but we want to check with our pathologist. Okay? So this is just free consultation. we'll see if we can just monitor it or if you need some type of another treatment. Okay. Okay. But don't scare them. Okay. Like even though sometimes it looks like maybe very unusual. Okay. But don't just say like it looks like cancer or something like. So yeah, just don't. So we are gonna ask for pathologists, okay, and we are gonna ask their opinion because they are specialists. Okay, we just want to make sure this lesion is okay. Yes.
If we see a lesion and we think it's a fibroma and DDS, like Dr. Jewel.
Dr. Jewel, yeah,
Do we still
if
do
they
a
come,
consult?
no, that's a good question. If you're general attending faculty, comfortable with the lesion, you don't have to call oral pathologist. Okay?
So I would start with your dental
Yes,
hygiene
yeah.
faculty first, because we'll be
Good
able
point.
to
Yeah.
say whether it's
Yeah.
allergies or that's common. If we don't know, we'll call Dr. Jewel. If
Yeah.
that doesn't work, then we call the pathologist.
Yeah, very good point. Yeah, I usually start. So if I'm comfortable with the lesion, I do diagnosis. But if I'm not sure, I just tell student, let's go oral pathologist. Okay. Objective. So location. So buccal attached gingiva, right? Above tooth number 13. Okay. I think that's mirror image. Sorry. So, okay. Sometimes mirror image is little. Is it mirror image? If it's not mirror image, it's going to be 4. Okay. But sometimes you need to just make sure. Okay. Lesion type, macule. Macule is flat, but less than 1 centimeter. Okay, usually. So I measured that one with perio probe. Okay. Shape, little irregular. Color, purplish, little dark gray. Okay. Texture, very smooth. Consistency, smooth and flat. Number, single lesion. It's not well defined, irregular border. Texture smooth. Pain, no pain. My intro lymph node exam was normal. So what's your assessment? Amalgam tattoo, or what's your differential diagnosis? Yeah, amalgam tattoo and melanoma. Okay. And what else? What else?
Trauma from a pencil or trauma from a pencil?
Oh, trauma from pencil. I mean, possibly, yeah. Because so I put amalgam tattoo, so it's your differential diagnosis, or melanotic macule, or some mucosa nevus. Okay. So plan. Are you gonna do biopsy? Maybe not, right? So just put plan that what will be the best for the patient. Okay, you can still monitor periodically. So you will see the patient for recall cleaning, right? So you just put monitor and then monitor for any change, any size change. So it's really important to put size too, because next time you can compare, right? If the size has been changed or not. Okay?
I have a question.
Yes.
So can it, like, it just seems like it's so close to like the apices of the root, but that's not, it couldn't be anything else like that?
Sometimes it can be if patient has some root canal therapy throughout the apex, apicoectomy. Sometimes it can be some scar from them. Okay, so that can be your one of the differential diagnosis too. Okay, yeah. That's
I would put question mark probably. I don't know.
So that's okay if you don't know, but you just put, the close diagnosis, and then you can confirm with faculty. Okay, that's why we have oral pathologists. Sometimes I don't know too. Sometimes it's very odd. Okay, I've never seen this kind of lesion. Let's give oral path consult. Okay, the plan can be monitored. So again, where do you need to document it? Page 3. So where? Under? Yeah. That's the bottom of page 3. That's the last part. You just double click, blank page, you just type. Okay? And then you need to draw. Again, draw. Okay? And they hit OK. Okay. So I have another example, but you can just, this is a little invasive one, or you can just read through. It has basically same explanation. Okay. Do you have any question about oral path sub and consultation? So basically same. Yeah. Any question? Yes.
So I just want to make sure we can always go back to the book that they have, correct? We can always use that.
Yes. Yeah. Yes. Any questions? No? Thank you. Thank you guys.
That was a lot clearer, right?
Yes.
More than really fun. I really like oral path. I know you guys are not liking it. But I really like oral pathology because it's actually, you're scoping stuff out and trying to figure out what is it. So it's kind of fun. But anyways, we appreciate it. Thank you.
You're welcome.
And what I'm going to let you do is take a break and then come back and we're going to talk over some other things. So don't be late.
Oh, no problem.
It was okay, Doctor.
Thank you for having me.
Dr. Fitzpatrick will come again. 2 weeks.
Because we have short
Oh, it's perfect.
he just let me work.
Okay, perfect. Thank you again. I think Susan Rogers will be the first one. Just get started.
Yeah, because they start seeing.
Before they finally pick us.
Is it okay if I ask a question?
Yeah, sure.
So
On a first part subjective, so when we go to lexicon,
the medication, yeah.
yes, they mentioned for the adverse reaction.
Adverse reaction, we usually focus on cardiovascular.
Oh,
I'm
not all of them,
not all
because
of
that was a law, so I didn't know I should mention all of them or not
I
just
had a slide about that.
just vascular, yes?
Yeah.
Okay. Not all. Because some of them that was about xystomia, dry mouth, or about the breathing, coughing. Okay, not all of them. Okay. And we should mention it
So
on it.
under adverse reaction,
Yes.
adverse reaction include,
Yes.
we usually focus on
Blood
BP
pressure,
and pulse. So
vitals, okay.
if they said, because we need to always, BP is important, and then we are using echo, so we want to know about pulse, right?
Yes.
But I'm not including like vasodilation. I mean, it's not really like relevant
we had
to
homework,
yeah.
so I mentioned
we
most of
usually
them,
mention
but
these. Yeah,
just vitals,
And
reacted to
then
vitals.
Yeah, and dental student, we teach if it's less than 1%, you don't have to. But I
Got
didn't
it.
go over that part here.
Yes.
But yeah, just,
Okay.
you don't have to
Yes,
worry about
I didn't
all
mention
the-
all the 1% because I thought that's too low.
I know, too much. So.
Got it.
Yeah. Okay. Thank you so much. Oh, no problem.
And it's like different to finally figure it out. And like even during arrow, and I was like, no, I went to see I was gonna go there, but
Are you guys like freezing in here? Or am I
it's so cold.
Yeah, it's and it's on like 95%.
I'm working on receiving
Hi there, it's Charlie. It's freezing in 1176. Is it possible to raise the temperature a bit?
That's weird.
Thank you. Bye-bye. Okay. I was sitting back there going like this.
Yeah, that's it. And then it just says, alright, we're here at 7. Yeah, maybe it's dinner, but for exercise, there's time to take as many pictures of the photos as you would like. And then I mean, I pushed it down, maybe to just do something like appetizing. The dress is formal. And you should also. I'll do it.
I did do it right.
What is wrong with you? I'm serious. Just put them on top of his instructional one. You're free.
Serious?
Basically, what I did is I just there, and then I took it from the section, and so I just went step by step. But a couple of these, I was like,
Do you say formal dress code is recommended? The event is formal dress is required?
required?
If we spend 42
I'll show it out again. The 3/4 one is I wasn't sure if that's what you wanted. Oh, and then I also needed to like shorten it.
Is it red or?
I was so confused.
Oh, okay, that's okay.
Stop. There will be an open mic during dessert.
Open mic, I was like,
Chef shot. I think so, but what do you mean? I don't know. Yeah, we did it today. The first one that you said how
I don't know, I was just so like in the moment.
yeah.
And I was so hard to listen to. Everyone is so much
It's going to be once every 6 months. I had one prior, just prior. Yeah, but it was registration.
No, my brother.
Yeah.
No, you don't have, it's not every 6 months. It's either once a year or once every other year. Alrighty, if you guys are taking seats, okay, I was like, did I miss something here?
And I thought like in general from where I thought like I was the website. And I looked at, I was coming around, I was like,
Okay, I was like looking out for you.
that was my fault. Yeah, I was right.
They're calling you vegetarians
Alrighty, let's get started here. So the first thing I want to talk about is last week's quiz. Okay, so I am going to make an adjustment to it, and I'm going to tell you the background to it. Some of the students have been coming to my office, they've been emailing me, texting me, I get it, I understand. So here's the rationale for what I gave you. Here is the appointment schedule, and it says review health history in capital letters first, then take vital signs and record them. Okay, I understand, and now I'm trying to figure out where all the miscommunication went from. I contacted Miss Hayton while some of the students were in my office, and we talked to her about that. And she said, well, some people were doing, was it a MedComp thing that they were all saying, and everybody was doing vitals first.
Yes.
Okay, but when I talked to her about the rationale for why we were doing this, she said, I get it. That makes sense, we'll fix it. So here's the deal. I know some of the faculty have been taking shortcuts because Wednesday is a short clinic, and they've been encouraging you to get as much done. But in an effort to help you to do that, they're not following the protocols that we set in place. So I am, after we have our conversation, going to send out an email to the faculty and saying, I know it's Wednesday and I know it's short, but I don't want you to cut corners, because if you cut corners, then now you're going to cut later and later and more. We give you a little bit of leeway, but there's a reason why I put it this way, and that's the reason why we were wanting to do it. So for example, if you come in and Emily's my patient and I say, hi, my name is blah, blah, blah. Okay, I'm going to take your blood pressure. Okay, they're already rushing, they're already coming in. You have not developed a rapport with the patient. You know how important that development of rapport helps to relax them to get an accurate blood pressure. Not when they're rushing, they couldn't find parking and they're late for their appointment, blah, blah, blah. By taking that blood pressure first, you now already caused a problem. If the blood pressure is too high, and you end up having to take your, do your medical history and then have the patient retake the blood pressure, that's wasting your time, because now the blood pressure is already unusually high because of all the rushing, no rapport, etc. And then you have to wait 20 minutes or so to take it again. You wasted more time because now you're taking bottles all over again. There's a reason why I put it this way. The reason why we should update that. Because if in the medical history, we can't treat them, then you're taking the blood pressure for nothing. You're taking the vitals for nothing. I mean, yeah, it's good for them to know it, but you're really not going to treat the patient, so why do that? Does that make sense of why it's more important to me to take your health history first, to know what you're going up against? I need to know, okay, they have a health history, a history of hypertension, so now I'm going to be looking for that when I'm taking that blood pressure. So I know that, okay, when I do all this, I'm going to be pumping up, or what their average blood pressure is, or where, just to get an idea before I'm starting to do the vital sunshine.
I was going to say too, when you look at their health history, you can kind of gauge on where their blood pressure would be, so that you're not just kind of all over.
Agreed.
I see the vital signs on the first page anyways, though?
It happens to be the way they where Axium is set up. Axium is set up that particular way, and it's a company that made it. So it just happens to be where that page is.
So do you recommend, like, even, I know this is the protocol for here, but when you work in clinic or you finish school, you recommend it being that way?
I do in my private practice. I don't want to sit there and go, okay, I'm going to take your vitals. I'm going to develop my rapport. I'm going to ask them some questions. I'm going to get them relaxed a little bit with who I am, because it's not always that they'll get the same hygienist. Like, who are you? Where's my normal Tuesday girl? That's usually there. Well, I'm subbing for her. Oh, okay. It's just something that I normally do just to kind of develop some rapport, figure out what I have, what I'm looking at, and have some conversation with the patient first. AJ.
I think you answered my question, but it says review health history first. Can we review the health history without them even in the chair?
Yes, you should always review that first, but reviewing it with the patient.
Again, okay.
Yes, because things have changed. You don't know if they had a heart attack a month ago, and the medical history never said anything about a heart attack. They might have had a stroke 2 months ago, 3 months ago. You never said anything about that in your review, so you have to review it with the patient. Okay? Any other questions about that? So I understand the reverse and the roll. I'm going to give you credit for that. I'm not that unreasonable because I just look at them and whoa, something is way off with this. But I wanted to have that conversation with you first so you know where we're coming from. I did post it here, and that's what I would like to see you do is update that medical history and develop some rapport, and then go ahead and take vitals. Okay. Yes.
What if we have rushy patients?
What if you have rushy patients?
Yeah, we just tell them to
Deal with it.
we just do.
Deal with it. You're going to have all kinds. Believe me. Yes.
Once we get in the normal swing of things, about how long should it take to go over the health history of the patient?
That depends. If you have my medical history, it's going to take you 5 minutes. If you have some lady that brings in 12 medications, it's going to take you a half an hour because you have to soak all those medications.
Would that be the same in private practice as well?
In private practice, I don't soak meds, but the reason why we're asking you to do some of these things is so that you can get familiar with drugs and what the interactions are. I know that. I know lisinopril does this, this, and this. I know I have to worry about, orthostatic hypotension with certain drugs. I know certain drugs cause xerostomia, but you don't. That's why we need to have you soak, and that's why we have you do certain things. It's to get you familiar. Out in private practice, you'll notice that's going to be here. And the treatment plan, the case presentation form, that case presentation form is to get you to think in a certain critical thinking process so that when I collect the data, I'll know exactly what kind of treatment plan I need without having to go through all of that. Because when I do my EOIO, I'm also looking at tissue. I'm doing multiple things at one time. I'm looking at the calculus buildup. I'm looking and looking and looking. I'm not just looking for lesions. So there's multitasking going on in private practice versus now yours is just looking for a lesion instead of looking at tissue, looking at buildup, looking at all of that. Okay, so it's a process, and we make you do a bunch of things in order to get you start to thinking that way, and then you'll start to go, well, I could do this at the same time as I'm doing this. I can do this at the same time as I'm doing that, and that's cool. When you start to click and start to know what things you can start combining, that's awesome. Yes.
This is a question unrelated, so.
That's fine. Okay. Let me just finish this and we'll go with your question. So what I'm going to do is all of you that reversed health history and vitals, you will get credit for those. Those that had it correctly, you won't get extra points for it because you already got it right. But those who did that. Now, is there anything else that was confusing? So, health history, vitals, instructor check. EOIO, instructor check. Now you watch seniors and they skip that first instructor check because they go in health history, vitals, EOIO, instructor check. Why? Because you're not there yet. I want to make sure that your vitals and your medical history is okay and safe before you start getting into someone's mouth. So we're going to let you do that, but not yet. So health history, vitals, instructor check, EOIO, instructor check. Okay, now we're going to start data collection. You do your data collection, and then you call your faculty over, and then she's going to check, and you'll come up with a treatment plan, and then you're going to do consents, all of that stuff, and then you start with plaque score and OHI. And you start your treatment. Does that make sense? Okay. So health history, vitals, instructor check. EOIO, instructor check. Data collection, instructor check. Sign your treatment plan. Begin with plaque score or hygiene. And then your treatment. Right?
Does the instructor check your plaque score?
No,
So we do plaque score and then we can just go into it?
Yep.
And then they just check the first scaling or whatever?
Yep. Good. Good. Starting to click?
Yes. How many points was that question worth?
9, I think. I'll double check it. I think it was 9. She bio instructor. Yeah, instructor. I think it was 9.
So there's data, then
Instructor check.
instructor
And
check.
treatment plan. Okay? Yes, Emily.
What about times?
Times meaning?
There was a question regarding, I think it was the earliest that your patient.
The times. So what is the latest that your patient should be dismissed from your chair? In the morning? 11:30. In the afternoon? 4:30. The reason why we want them out of the chair is because it's going to take us that long to do all your signing, all of your, your notes, approving this, your self-reflection. If I let you dismiss your patient at 12, I'm not going to have a lunch, and neither will you. Okay, so we get them out of that chair no later than 11:30 or 4:30, so that we can work on our computer work, do all of that other stuff. All right? Any other questions in regards to the test? Okay, Rachel, you had another off-subject question.
Yeah, maybe you guys can refer to the printed schedule that we got at the first week of school. Is that the most recent?
The most recent I put in, the module in clinic.
Okay.
Check the dates on the bottom right, because they'll...
Bottom right. Okay. What is the most recent date then?
April, what was that April date?
3/25. Okay.
No, it's April. April 1st.
So 4/1. Okay, 4/1. All right.
Okay, anything else?
Can we maybe get a printout of that? Can I suggest that? Like from Barbara? I mean,
she handed one out. Oh, she changed it since then, right?
Yeah, so that's why I'm a little bit,
It's on the module. It's on the
okay.
Yeah, I put it under module, so you should be able to just print that.
Okay, cool.
Okay. Anyone else? Any other clinical issues, questions, inconsistencies? I'm working on that with the faculty. We have a lot of new faculty that joined our staff. I think 4 in the last 3 months. So they're trying to learn the ropes too and trying to get calibrated. We did have a faculty calibration meeting a week ago Friday, so hopefully things will start to settle out. And you should know a couple of those things should start coming together. I will send out that email this afternoon as soon as class is done to tell the faculty we had this meeting. Don't cut corners just because it's Wednesday. We want you to follow through with the protocols. Sunshine.
So if we have a patient that we don't complete, it's incomplete, and then they pay the $53 to get the treatment done, when they come back, are they paying another $53?
No. In fact, they should not even pay. You only pay when you have completed your treatment totally. The last appointment, after you polish, floss, put on their fluoride varnish, that's when they pay. So don't collect money.
So for my patient, he did pay, so the next time he comes, he
No fee, because he's already paid.
Okay, thank you.
Yes? Adele?
So I'm still slightly confused on this. This paper, the assessment.
We're going to talk about that next. That's what our thing today is supposed to be treatment planning, but I was just updating some other stuff. Anyone else? Okay, let's talk about the treatment planning. I printed this up for you. So here's the history with all of this stuff. Normally, that treatment planning lecture that you get, I probably have given that lecture for the last 15 years. But this year, Miss Lennon said, oh, I'll do it. So normally when I do that lecture, this comes like this on a laminated form. So what she's doing is she's updating that laminated form and she's changing a couple of things before she has it laminated and given to you. So what I've done is printed you up the latest form. What you could do is put it in a sheet protector and start writing on it with your pen. so that you can use that and wipe it off and use it as a laminated sheet. Okay, this is the most current. I don't know, she's working on a couple of little other things because the period diagnosis changed radically over what I had from last year. So she's made that modification. She added this other thing about insurance up here on the top, and whether it's cash insurance or Denical, which is cool. Great addition. So she's done a couple of little updates to this sheet, and I'm glad it's there. But I'm sad that you don't have this form yet, and you're already starting to see your patients. So I printed for you today. Put it in a sheet protector like this. Hold it up, Kayla. Okay, so she has it all right there on a sheet like that, where you can start writing and using that, and then use it for your next patient. Use it for your next patient. Okay. The treatment plan. Is there anyone that has questions on how to complete this? When we say complete, we mean top to bottom. Everything should be completed. This top section right here, most of that can be completed before your patient comes in. So you can already get that ready. Some of it may change a little bit the morning of, but pretty much that's what could be completed earlier. So you can get that done. This radiographic section, after you get your new current x-rays, you can look at that, fill that out, and it's just check marks. It should take you a couple of minutes to fill this out. If you're taking 20 minutes to fill it out, it's too long. Okay. Yes, Danny?
Are we getting a laminated data collections sheet as well?
You're supposed to.
I don't know.
She gave us the sheet. You have to get the laminates yourself.
What?
Yeah, I have one.
What are you talking about?
They give us a laminated.
I have always,
have
when I
one.
give that lecture, I've always printed that up. So you laminated it yourself?
Yeah.
Okay.
Right now they're just. They've given us like paper ones.
Yeah, okay, so here's the deal, at least for the last 15 years when I've done this. I did this actually 2002. It says on here 2002 is when I first created this sheet. So it's been more than that. It's been 17 years. 17 years since I made this first sheet, and it's been modified since. So, and it's funny to look at what the old one looked like. It didn't have near this information, but it was really helpful way to get you to start thinking, hey Leo, any chance we can get it warmer in here?
Leo?
Hello? Go stop him. Any chance we can get it warmer in here? They're all freezing.
It's cold?
Yeah.
Ladies, I've been working out.
Okay, so anyways, when you get your laminated sheet, you should also get a laminated perio sheet. Okay, I don't know why yours are taking so long. Like that one.
She gave us one, but not laminated.
No.
I can see it updated.
Okay, so she is going to get it laminated. I talked to Barbara this morning, and I said, Barbara, where's the laminated sheet? She goes, oh, I know, she keeps making changes to it. So, but anyways, it's coming. So any questions on this? All right, so let's do a couple of little exercises and see if we could come up with this. And basically I'm looking at concepts. So if I have a patient who's 25 years old, there's no significant medical problems, taking only multivitamins, there's your vitals. The last exam they had was 6 months ago. Last FMX was 2 years ago. Last bite wing 6 months ago. Last hygiene appointment 6 months ago. Radiography was basically no bone loss. You got pockets, 2s and 3s, no furcation, recession, mobility, and I should have put Cal. You got some light plaque, a little bit on the molars, a little bit of supra on the bottom, no stain, no real subcalculus, just some root roughness, minimal bleeding in the posterior anterior, 28 teeth, chief complaint, they just want a cleaning. What kind of treatment do you think you're going to do for this type of patient? what treatment plan, and there's only 4. Prophy, actually 5. Prophy, scaling and root planing per quad, scaling and root planing per sextant, perio maintenance, perio re-eval, and then there's the scaling within the presence of inflammation. That's it, there's 6. Okay, so what are you going to do for this patient? Prophy. What does prophylaxis mean? Prevention. Does this patient appear to have disease? No. So, you're going to do a prophy. Do you mix prophy with root planing? No. Do you mix prophy with maintenance? No. Do you mix prophy with a re-eval? No, not really. Okay, so this is a good practice one. So here's another one. I want you to take a look at it. Yes? Oh, okay. I'm talking about dental treatment, not fluoride or any other extra things. Prophylaxis, adult prophy. Scaling and root planing by quadrant. Scaling and root planing 1 to 3 teeth only. Scaling within the presence of inflammation. Like they have so much calculus you can't even probe. You just want to just flush it all out.
These are all the dental codes, right?
Yes, that's on your treatment code. You have, after you scale and root plane, what do you need to do? Re-evaluation. And how far apart is that?
4 to 6 weeks.
4 to 6 weeks. Did we get them all? Perio maintenance. After you scale and root plane, you do your re-eval. Perio maintenance is what you'll do at your next treatment. You're maintaining the perio condition. Okay? So let's look at this patient. You have an 18-year-old female. No diseases or illnesses, no drugs, basic. Last exam was a year and a half ago. Most recent FMX was 5 years ago. Last bite wing was a year and a half ago. Last hygiene appointment a year ago. There's no bone loss, minimal history. Pockets about 3 or less. No furcation, recession, mobility, or cow. Light. 32 teeth. But the complaint is they get a little bit of bleeding, some tooth sensitivity, cold along the gum line, and the patient is interested in tooth whitening. So, tell me by looking at this, what radiographic needs does your patient need? Okay, I got FMX, I got bite wings. Which is it? FMX. Why do you say FMX?
5 years ago.
Okay, 5 years ago, man, let's get a new set of x-rays because we don't know what's going on. Now, what if that said bite wings 6 months ago? But last FMX was 5 years ago.
Still FMX.
You would wait until the next time they're due for bite wings, and then you take your FMX. So you don't want to keep radiating them because the bite wings are still current. But you wait until it's time to go ahead and take the x-rays, then you take the FMX.
So it's like a year. So you need
maybe, yeah.
Dr. Jewel to say, get an FMX,
Yes.
and then you get it.
Yes.
You don't just send them over.
Exactly. She has to diagnose it's okay to take these x-rays, and then you can go get a chair. Good. All right. Now we got the radiographs. Yes?
Quick question. Every when do we take an FMX? 2 to 3 years?
It's 3 to 5 years, and it varies. So now here's the variation. If it was on me, I hardly have anything in there. Probably the last 20 years or so, I haven't had any fillings. I had a couple of little patches from when I had ortho because the band was loose and it caused a little bit of enamel to erode away. But other than that, I don't have any decay. I'm not decay prone. So for me, every 5 years is probably better. Now, if I have Mrs. Jones here, she's got a ton of crowns and bridges and implants and blah, blah, blah. I might want that FMX more every 3 years or 4 years closer than 5. So there's a little leeway when we say 3 to 5 years. Depends on who I'm working with and what my risk is for decay or periodontal problems. Now, if I got a person that has a ton of bone loss and they got a bunch of restorative, I'm going to be closer to my 3 years than 5.
So it's 3, like
It's 3 to 5 years. Okay. So now you've got this. What do you want to do as far as a treatment on this type of patient? How many say we're going to do a perio maintenance? Okay. How many say we're going to do scaling root planing? Okay. And how many say we're going to do a prophylaxis, a regular prophylaxis? Okay. So let me go back and explain. A prophylaxis is done on a patient that doesn't have any periodontal disease. What we are trying to do is prevent. Prophylaxis is prevention. We're trying to prevent them from having any periodontal issues. If they have bleeding and maybe a little inflammation but no cal, they just have gingivitis. Easily taken care of by doing a straight prophy. They just need to be clean. It's time. All right? Yes?
So with the prophylaxis, can we also do a light scale?
You're always scaling. A prophylaxis means you're doing a cleaning that's prevention, but it doesn't mean just polishing. Absolutely not. I'm doing a prophy and I'm scaling all over the place.
It's like our adult prophy.
It's adult prophy. That's your prophylaxis. So when we say prophy, don't think I'm just going to polish. Not the case. I'm scaling, polishing, flossing, just like I would another patient. Only I'm not going way sub, way deep. There's no periodontal issues, not a bunch going on. Can there be calculus? Lower anterior? Yeah, we all get it. Right, AJ?
Now, if they had heavy calculus and inflammation, that'd be
We're getting there. We're getting there. Okay. So we got this. Everybody agree prophylaxis? Now, why wouldn't it be a perio maintenance? Okay, there's no previous periodontal treatment, hasn't had scaling root planing, so there's no perio to maintain. Perio maintenance. We have nothing to maintain because it's still healthy. Just got a little bit of gingivitis. Okay, and chief complaint is whitening. You're going to always address the chief complaint. You will see that on your national board exam. Okay, always address the chief complaint. Now, if the patient had a ton of bleeding, inflammation, calculus, bone loss, but they say, oh, I really want to get my teeth whitened, and the teeth are flapping in the breeze, okay, you ain't going to have any teeth to whiten. Are we going to address the chief complaint?
Yes.
Yes. You have to still address it. Are we going to tell them, yeah, we're going to whiten your teeth and we're going to pull them all out? No, but you still have to address it. You still have to talk about it with your patient. Explain why we're not going to do that first. We're going to try to get your condition under control first, and then we'll go to the whitening. But you have to address the chief complaint. Always.
Would you still suggest whitening for this patient because of their tooth sensitivity?
You could, but we need to find out why the patient's sensitive. Okay? They're sensitive along the gum line. It could be there's decay there. It could be that they're brushing so hard they have abrasion. It could be there's recession. So we need to figure out why they're sensitive. There's also bleach that comes with fluoride, and so that might help too. All right. Is this helping you understand treatment planning a little bit better? Okay.
Are we learning about bleaching at all?
You will.
Okay.
And you're going to make your own bleach trays? Yes.
Do you bleach our own teeth?
Yes. Yes. That's coming this summer. So you guys will all make your own bleach trays. But before you do that, they're going to make you take impressions and get it right before you make your trays. So it's going to be fun. You guys are going to have a lot of fun. Okay, so here's another case. You have a patient, 45-year-old female, has had a congenital heart valve replaced 1 year ago. There is no other medical problems, no allergies. They had an FMX 2 years ago. Do we need an FMX? No. The last comprehensive exam was 2 years ago. Do they need an exam? Probably, yes. Last hygiene appointment was 2 years ago. Been a while.
Yes.
Radiographically, there's moderate bone loss, slight mobility, and frication involvement. Okay? They've had moderate past restorative work done. Okay. Here's our dental exam. Moderate generalized plaque calculus in the upper right and upper left, and moderate to heavy on the lower right, lower left. Here's our probing. Upper right, we got pockets to 9 millimeters with a 3 millimeter at 3 class 3 frication on just 1 to 3 teeth. We got some to 6, some to 6 to 7, some posteriors only. 100% plaque score. We got frications all over. The tissue's red, inflamed, bleeding moderately in all quadrants. What is that screaming at you? The data's screaming. SRP. It's screaming SRP all over the place. Okay. Bleeding, red, inflamed, bone loss, cal. It's screaming SRP. But we're going to figure out what kind of SRP are we going to do. Okay, that's the last one. So let's break it down by quadrant. The upper right has a 9 millimeter frication on the buccal number 3 with a class 3 frication. Does this patient have a perineal problem?
Yes.
Yes. Are we going to do a prophy on this patient? No. Okay. But it's only happening in the upper right on just 1, 2, or 3 teeth. So what are we going to do for this patient in the upper right quadrant? We're going to scale in root plane the whole quadrant? Just 1 to 3 teeth. We're going to treatment plan it for scaling and root planing 1 to 3 teeth. Are we going to skip the rest of the teeth? No, we're going to clean them for free. We're going to just do that whole quadrant. Okay? On this one, lower right, on the right side, on the bottom now, has pockets to 6 millimeters in more than 3 teeth. What is our treatment plan for that quadrant? Scaling and root planing by quadrant. Is it different? Yes, because the periodontal problem on the upper was only a few teeth. The periodontal problem on the bottom, whole quadrant. Treatment plan, scaling and root planing, the whole quadrant.
I have a question. So when we treatment plan this on axium, do we have to do each separate?
Yes, yes. And I'll show you how to do that. I'm adding in an extra lecture for 2 weeks from now on axiom and how to do all that stuff. Because somebody asked me to, and I'll just make it up and I'll do it. I haven't done it yet. Okay, so the upper left. Now, they have pockets 6 to 7 millimeters in the posteriors. 1 to 3. What is your treatment plan going to be? Scaling and root planing 1 to 3 teeth in that upper left. On the bottom, 5 millimeter pockets in the posteriors only, greater than 3 teeth. SRP by quad.
So basically, whatever it's over 3 teeth, it's a quad.
Yes. Yes. Okay, plaque score is 100%, so we're going to focus on OHI. And here's the key. I always tell my patients, we're going to be doing this deep cleaning. What I'm going to do is I'm going to go in with my water sprayer. I'm going to go in and flush things out from the base of the pocket to clean it all out. Then we're going to smooth up the surface with our hand instruments, right? Because we're going to plane it, root plane it. Then at the very end, we'll polish up your teeth, when we're all done. Okay? But this is a joint effort. I could do the best job I can with scaling and root planing, but if you don't do your job at home, our treatment's going to fail because it's a partnership. I need you to do your job at home, and I will do my job here, and we can see if we can turn this disease around. So I put the OHI on them. I'm going to give you all the tools and all the things to do. I'm going to do my job with my scaling and root planing, but if you don't do your job at home, this will not be successful. And then you do your OHI. So they need to take ownership. And we're going to talk a little bit about ownership next week and making them responsible.
Excuse me, when is it that we are going to be using our Cavitron versus hand scaling for something like this?
So, for me, I don't work without a Cavitron. I Cavitron everybody that walks through my door. Okay? I use it to flush things out, deplaque, because you know how long it takes to scale and you got plaque and now you're wiping it off and flush it all out first. Then you hand scale. So if I'm doing a basic prophy, I'm going to grow scale with my ultrasonic first, go in with my hand instruments last, scale, polish, floss, done. If I'm doing quadrant root planing, I'm going to ultrasonic that quadrant because I'm only going to work there. Get that quadrant done with my ultrasonic. Then I'm going to hand instrument. Then I'm going to explore. We're done. That's my whole appointment. Or I could do 2 quadrants of that. Don't polish because you don't polish when you're scaling root planing initially until the re-evaluation 4 to 6 weeks later because we want the tissue to heal. We don't want to get all that pumice and all that stuff all up underneath the pocket that's trying to heal up. Okay? Yes.
So we only polish at the end of the package for prophy.
Yes.
Profile.
Yes. All right. Any questions about this particular case? We look here. Red scaly lesion. Who needs to see this patient? Oral pathology. Okay, so you have to think, what else do I need? What else does this patient need? What else can we do? All right. Any questions on this case? I'm going to back up here. Right here. Patient has a congenital heart valve. Pre-med. What would you pre-med for this patient?
Amoxicillin, 2 grams.
2 grams of amoxicillin. How many tablets of that if it's 500 milligrams? 4. Okay, Lucia.
Would you also do a perio consult?
Yes, you would do a periconsult. Whenever we scale and root planing, we usually have a periodontist come by and say, yeah, we agree with that. Sometimes they'll go, you know what? This case is a little bit too over your head. Send it to grad perio. And sometimes they'll take it away. Oftentimes what the hygiene faculty will back you and go, can we just do the scaling and root planing and then we'll refer them to you when we're done so that you guys can get the experience. Yeah, we want you to have it because you're going to get out there and you're going to be scaling it in 9mm products. You're going to learn how to do it here. Okay. I think we're good there. All right, here's your patient. High blood pressure. Had a heart attack 4 weeks ago. What's the first thing that went? Should we go ahead and take their vitals first? No. Why waste your time? Update your medical history and you know right away you don't need to treat this patient. You see why my thinking is you don't take vitals first? Okay, let's update our medical history. So let's say the patient's not 4 weeks away, because when should we treat them? 6 months. Good. Let's say it's been 6 months, so ignore that. The patient's on Coumadin, it's a blood thinner. Hydrochlorothiazide, it's for a water pill, and a high blood pressure medication. Look at those vitals. What do you think? Too high. Too high for us to treat?
Yep.
No.
Well, the humidity is 160.
Yeah, it's not looking good all the way around. So I probably want to have, if this were the case, to have someone take a look at them, maybe a med consult. But you're still within treatment level, right? Because it's 160 over 110. So you could technically treat them, but with all this other issues going on, I might have the patient see their physician. Okay, so last FMX 2 years ago, do we need an FMX? No. Last bite wing 6 months ago, do we need bite wings? No. Last cleaning 6 months ago, last exam 6 months ago. Radiographically, there's slight bone loss, less than 25%. No previous history of SRP. Light plaque calculus, stain, inflammation, probings to 4 to 5 millimeters. Furcations 1 to 2. All quadrants, plaque score 20%, 30. What are you going to do for this patient? It's right between cases, right? So sometimes you have to judge by looking in the mouth. You have to figure out why is the probings 4 to 5 millimeters in the molars. Okay, so here's an example. The patient has third molars. They're coming in, but they're not fully erupted. Okay, they're partially erupted. So when I go to probe that, if it's partially erupted, where's it going to be? Deeper or shallower? Deeper, because it's coming through the tissue. And so I might probe 4 or 5 around those third molars, all of those. So I need to know why the tissue is like that. Why is the probing at 4 to 5 millimeters? What's causing that 4 to 5 millimeter loss?
When someone's 55, do you usually see or the molars coming in?
Sometimes. Sometimes they have teeth that are coming in this way and it's locked and they can't ever come in because it's coming in at this angle. So they can have what they call a pseudo pocket, and that might be something that might be there. They could also have periodontal problems on the back molar because they're not able to clean it or it's deeper. Okay. So, it depends. That's why I kind of threw this in. It could be a pro-feed, depending on what's going on, because we're preventing disease. If that pocket's 4 to 5 on the third molars that are coming in, they still need prevention. Everything looks good. Maybe some slight bone loss, but maybe some scaling and root planing. So I'm going to just leave it at that. All right, last one. Here's my patient. Has history of high blood pressure, high cholesterol, taking the medications for those two. Patient was rushing this morning and they had coffee. So what is their blood pressure doing? Okay, so what are we going to do first to calm them down? Review their medical history first. Okay, so last exam, last FMX 2 years ago, do we need an FMX?
No.
Last bite wings 3 months ago, do we need bite wings?
No.
No. Last exam 3 months ago, do they need a doctor to look at them? No. Last cleaning 3 months ago. Last root cleaning 1 year ago. Does that red flag you to go, Okay, so slight bone loss, slight to moderate bone loss, about 40%. So what does this tell you want to do for this patient? Perio maintenance, because they already had a scaling and root planing, and now we're just maintaining the perio condition. But look at, they have light plaque, light localized calculus here. There's moderate staining. Probings are still 4 to 5. Is it okay? It's not perfect, but there's a little bit of loss. So we're going to maintain the perio condition right there. We don't want any more loss. We're never going to get the bone back that got lost, but there's going to be a pocket. So if I showed you a patient that had 4 to 5 millimeter pocket depths and go, what's the treatment plan? Can you make a plan without knowing what the history is? You can't. You can't just look at someone and say, oh, you have 4 millimeter pockets, you have gum disease. That may not be the case. All right? So tissue is fairly pink and firm with some slight in the posterior, little bit of inflammation, just slight. So it looks like the disease is pretty much almost arrested, and they're almost back to where they're healthy, even though they have a periodontal condition. There's a little bit of cal, a little bit of clinical attachment loss, but all in all, they're doing a really good job, it looks like, of maintaining it. So we're going to do a perio maintenance.
So I have a question. Like the perio maintenance and the SRP, so we're still scaling, we're still flushing out and scaling on both of those, right?
Okay, let me back up. Don't mix terminology. On the perio maintenance appointment, you're going to still do your ultrasonic, you're going to scale. Pockets are going to be a little bit deeper, but you're still going to scale and polish and floss.
And SRP?
SRP, You're going to do some active treatment, active therapy. You're going to really actively go in there and plane and plane and plane and plane that root. Get it all clean. Wait 4 to 6 weeks and then recheck the data. See if what you did any good. And then go back in. Polish. Put them on a recall. Start again. Does that clear up your treatment planning stuff? Yes. Okay. So, next week, we're going to talk more about, now that we've gone through data and all that stuff, we're going to talk about OHI. And after this lecture, OHI competencies can be started. Okay. All right. See you guys.
Yeah.
You're gonna try one more clinic first?
And I think I'm a floater. So. Thank you.
Hey lady. Hi, how are you? Fine, how are you doing? Getting out of here.
No worries.
No worries. I'm getting here with Dr. Hayataki. Okay. And then once I get the camera. I'm not the only one there. Oh, yeah. Okay. I brought in vegetables, but I didn't usually let out. Okay.